This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, in this video we'll answer the question, what should be our step-by-step approach once a bowl has formed in an eye with soft cataract? In this video we'll try to answer this question. My last video on prevention of bowl formation was well received. The most common comment was hydroprolapse of the nucleus out of the bag is the easiest technique to prevent bowl formation. Well, it's very true. However, hydroprolapse may not be possible in every single time. Number 1. The most important prerequisite for it to be easy is to have a larger axis. It would be difficult to prolapse the nucleus out through a CCC less than 5 mm unless the nucleus is very small. The ideal CCC diameter which we usually aim for is 5 mm since that ensures a good refractive outcome as it ensures a predictable ELP. The 5 mm CCC may not be good enough for certain cataracts which have high risk of bowl formation. But unfortunately, we realize this only after the CCC is done and we are into nucleus management. The second critical aspect is the size of the endonucleus. And this depends on multiple factors. The younger patients have a smaller endonucleus and they can be prolapsed out easily. On the contrary, patients who are above 60 years or patients with just cortical cataracts, it might be difficult to prolapse the nucleus out through a 5 mm rhexis. So in a situation where the CCC is already done and now we are stuck with a bowl which is formed, how do we deal with this situation is the crux of this video. So let's watch it. Hi, and this is a case where a young senior resident is performing surgery and she ends up having a bowl. And having a bowl can be a very intimidating scenario for most beginner surgeons, and let's try to analyze this case and how to work around it. Now, he's a 60-year-old male patient who has been posted for phacoemulsification. The rhexis is done. It's of decent size. A good hydro procedure is done. The trench is created. The trench is moderately deep but not long enough, and the surgeon is attempting to do the lateral separation. The first attempt is failed. The surgeon very wisely goes and tries to deepen the groove. And again it fails simply because the position of the instruments are not deep enough and the maneuvers are not reasonably firm. So she rotates the nucleus and tries the dividing maneuver from the other end and nothing happens. The only success which could be achieved was the separation of a peripheral part of the epinucleus, but the central nuclear component is just the same. So eventually we have a bowl formation. Now, how do we manage the situation? So one way to deal with this is to try to prolapse the nucleus out of the bag. Now, one can do it with the phacoemulsification tip itself, but the younger surgeons would be very intimidated and scared to do this simply because the phaco tip will be very much close to the equator of the capsular bag and there is always a risk of perforating the PC when you're trying to maneuver this. So the attempt was not successful. So now we have the classical bowl formation. The first recommendation always is to go and try to repeat the hydrodissection. The hydrodissection itself can sometimes prolapse one edge of the endonucleus out of the bag. It is attempted, but nothing happens. So the hydro procedures were not good enough to prolapse the endonucleus out of the bag. Now the suggestion was, why not prolapse the nucleus out of the bag manually using 2 Sinskey hooks, just like how we do for the M6 cases. So she's attempting that with help of 2 Sinskey hooks which go in through the side ports, and she's unable to grip the equator of the nucleus because the nucleus is so soft, it's crumbly, and she doesn't have a good hold to reach beyond the equator and rotate it up into the antechamber. So eventually that maneuver also has failed and now she is asking for help. So this is a situation which is not so uncommon with most beginner surgeons, and even sometimes an experienced surgeon can also find it challenging. So the principle to follow is somehow you have to manage to flip the nucleus out of the bag. So that is the basic principle to follow. But how are we going to achieve it and what parameters are going to play an important role? Let's try to analyze. So now I have taken over, and my plan is to go ahead and hold the epinuclear edge and flip it out of the bag. So the parameters which I'm going to use is predominantly just the vacuum and the flow rate. Flow rate to attract the lens material towards the phaco tip, and vacuum to hold it and then flip it out of the bag. The power is set to 10% longitudinal, which I'll not be using most often than not. My foot position is going to be in foot pedal 2 predominantly. So I go into my left hand side and then I'm trying to position the face of the tip so that it abuts against the lens matter. But as I'm trying to engage and pull it out, we can see that the grip is lost simply because there's not enough a ledge available of the lens matter or the wall of the lens matter available for me to hold it and flip it out. Another attempt is done, again similarly, it's unsuccessful. I need a sufficient amount of wall of the lens matter to hold it and pull it out. So I rotate the nucleus to a part where we have a slightly more bulkier portion of the endonucleus, which forms a ledge or the wall against which I can abut the face of the tip. So again, the tip is facing towards the wall of the endonucleus and the vacuum is allowed to build. And now I've got a hold, and then I'm going to flip this nucleus out of the bag. So now the entire thinned out bowl of endonuclear tissue has been pulled out of the bag and into the antechamber. The senior resident now is again allowed to manage the case, and the lens matter is eaten in toto. The case is eventually finished well. So let's go back and rewind. When you're stuck in a situation like this, a bowl is formed. So we'd want to use only the flow rate and the vacuum parameters and not the phaco. So important for the vacuum to build, there has to be some occlusion at the tip. The first principle to follow is ensure that the face of the tip is oriented against the wall of the lens matter. This ensures a quick and complete occlusion, because only once the occlusion happens, the vacuum is going to build. So if you have a first few failed attempts, rotate the nucleus to get into a position where we should have a reasonable amount of lens matter available so that the tip can be occluded and then it can be flipped out. So remember, no phaco to be used. We are only relying on the high flow rate and vacuum to engage the nucleus and flip it out. So these are very tricky situations. In a rhexis which is appropriately big, these cases are easier. But if the rhexis is very small, like maybe 4 and 4.5, even these maneuvers can be very difficult. And in these situations, it's very difficult to enlarge the rhexis as well, simply because the visibility will be very muddled. The anterocapsule and the cortex will all be looking the same, and it would be quite risky to enlarge the rhexis as well. So the message here would be, try to do a rhexis not less than 5 mm in all cases of soft cataracts, because even if you're stuck in a situation like this, you can easily bail yourself out. The second would be, whenever a bowel formation happens, you can always go ahead and try to do hydrodissection. Hydrodissection itself can prolapse the nucleus matter out. Well, in this case, it did not work, but it can be tried. So the principles to follow whenever we're stuck with a situation of a bowel formation. First, go repeat the hydro procedures. Try to do hydrodissection so that at least one pole of the endonucleus lifts up. When it lifts up, it's easier for us to go and grab it with the phaco probe and flip it out. Repeat hydro procedures and repeat hydrodelineation. Maybe you can just remove the endonucleus out if it's possible. Going in with the phaco probe should be the last effort, simply because it's much more riskier for a beginner to go and pull this nucleus out. There's always a risk of increased chances of PC tear happening during this maneuver. So when you're using phaco probe, avoid using phaco power. Just try to engage the nucleus with the vacuum itself and then flip it out. So that was it. Thank you for watching and hope you found this helpful.